Hello, welcome to DHR Health Talks. I'm your host, Dr. Dan Guerra. Today we're going to be talking about arthritis and joint replacement with Dr. Zain Sayeed, an orthopedic surgeon here at DHR Health Orthopedic Institute. Welcome, Dr. Sayeed. Before we get into the podcast, tell us a little bit about yourself, where you're from, where you went to medical school, where you did your training.
All right. From Dr. Sayeed, thanks for having me. Thanks for taking the time to meet with me today. I grew up on the south side of Chicago, went to school out there for elementary as well as into medical school. So I went to Chicago Medical School. Then after that, I matriculated to Detroit for residency. That was at Wayne State University. And that was about 5 years of training for that, for orthopedic residency. And then I finished off my specialization year in hip and knee replacement over at Harvard.
So there are different types of arthritis, obviously caused by infection, by trauma, by inflammation. But what would you say is the type of arthritis most common that you see?
So the most common arthritis is definitely osteoarthritis. And that's just pretty much the hibernation of cartilage around the hip or the knee. So the cartilage just tends to wear. But the way that I kind of break down arthritis is to two different major categories. One is inflammatory, and those are patients that are born with a possible rheumatoid disease, or maybe they had an infection when they were younger and then they just went on to have continued pain, residual pain, and breakdown of their joints, versus osteoarthritis, which is someone who's aging, just wearing down their bone. It's almost like the tread on the tire. It started to slowly wear away, slowly wear away, slowly wear away, until they are adding that bone-on-bone pain. And generally, that's when they kind of come and see me. And so there's hip as well as knee.
Okay, can you show on the model of the knee what leads to a knee replacement?
Yeah. So basically, I don't know if I can take this one out, but it's kind of knee. The knee has three compartments. So one is kind of underneath the kneecap. The other is the inner side of the compartment, or I guess this will be the outer side over here. But outer side is the lateral compartment, and there's a medial compartment. So there's three compartments of the knee, and each one can break down at varying rates. Sometimes you see people that are knock-kneed or kind of bow-legged, and they have different wear patterns, or maybe they had a sports injury in the past and lost their ACL. So different parts of the knee can wear out at different rates. And what ends up happening is that the cartilage sometimes just takes a hit and keeps taking hit, and they deal with pain throughout their life. And it eventually gets to a point where they come and see me. They might go to a primary care clinic office and get an x-ray. And they're like, hey, look, you have some degenerative changes. And once that happens, those parts of the body just continue to wear down until you don't have any joint space left. Or you have some different changes, maybe some bone spurs start to develop. But most commonly, patients just come in with a little bit of stiffness, pain that's on occasion, and then it just gets worse and worse over time.
And at what point in this process do you recommend to the patient, okay, I think it's time to maybe consider a knee replacement?
I always have kind of a couple rules. So one, that's about 5 things. I need, number one, an x-ray that looks like it needs a knee replacement. So they have to have some objective evidence of showing us that they need something for their knee. 2, is I have to have a patient that's had tried something before. So whether it be anti-inflammatories, therapy, injections. 3, I need a patient that has more bad days than good days. So they might have some arthritis, and some patients had a really, really bad looking x-ray. They tried things that continue help. They don't need a knee replacement. It's an elective surgery. But they have to have more days where they feel like, hey, look, this is not working out for me. I don't like to take these pills. I want something else to help me with my pain. 4, I need a physical exam. So I need to put my hands on the patient and pretty much say that, hey, look, this is an area that hurts, that matches the x-ray, that matches what they tried before, and also matches how they feel in my room. And that could be with me or any other doctor that has seen them before, and they usually prefer that to me. The last thing is I need a patient that is willing to learn about the process, is electing for the surgery. So they have to be ready for the knee replacement process. And it's an extensive process with clearances to make sure they're safe for surgery. On top of that, coaching them throughout the whole rehabilitation process and whatnot.
Okay. And how does a person, if they haven't been to a doctor at all, how do they know when it's time to consider a knee replacement?
Again, usually what ends up happening is they'll have something that happened. They'll notice a stiffness, or they can't sleep at night because of pain in their knee or their hip. And then they'll most likely go to their general practitioner or their advanced care practitioner to have an evaluation. And that person may refer them to get an x-ray and then come back to read that read. So if the imaging matches what they feel on exam, and maybe they have given them a course of anti-inflammatories or maybe an injection, if that's all matching and you could kind of see a little bit of wear cavern on the x-ray, at that point, they could most likely be referred to a specialist, so that way they can follow up and figure out kind of how to continue best managing their pain non-operatively or operatively.
And if a person is getting to the point where there is some wear and tear, are there any treatments available to kind of delay the process of a total knee replacement?
Yeah, I always tell my patients, I'm okay with you holding off as long as you want to hold off. There is a little bit of a trade-off in that, in the sense that is the ability to kind of recuperate from a knee replacement at maybe 90 plus is different than 75. But at the end of the day, it is the patient's choice and their decision. But what I usually recommend them to do is, one, a low inflammatory diet. So make sure they watch what they eat and kind of watch their weight as well. Two, regular walking. So they have to walk at least 40 minutes a day, regardless if they have pain or not. I know it might hurt, but I do recommend that, so that way they just keep mobilizing. And three, most patients could do kind of a weight-bearing exercise like yoga, as opposed to kind of hitting the gym and hit the weights. But I do highly recommend yoga because it stretches. You're putting only your body weight through your joints. And there's kind of a lower risk of kind of another kind of injury with the yoga exercise. It's kind of targeted stretching and using your own body as kind of a weight-bearing activity.
Are there knee injections available where you can give the patient some relief to kind of postpone the surgery?
For sure. So there's different types of injections. The two kind of major brackets are steroid injections and then kind of gel shots, or people call them chicken shots or something else. There's different types, but each one carries its own kind of benefits for the patient. Usually in my clinic, in my hands, I kind of more tendency is to go towards the steroid injection because I can kind of calibrate that from an insurance standpoint. It might be a little easier to approve it right away. But that is designed to give pain relief as well as decrease the inflammation. The gel shots are what they call kind of lubricant injections. So they kind of help with a little bit more of the inflammation side as well, but they also kind of helping glide the knee, kind of give it back its original substance called like hyaluronic acid back in the knee to help it kind of glide a little bit better. So that's definitely a possibility, and those two are always options on the table. And every doctor is different. Maybe some doctors will be like, hey, you had 3 of these injections and not willing to do anymore. But for the most part, people are willing to work the non-operative pathway the best they can, because surgery is, again, kind of our last resort for a knee or a hip.
Can you describe a little bit the actual knee replacement? I know we don't have the actual metal prosthesis, but using the model, what is actually kind of done?
Oh, absolutely. So let me just go and slide this puppy over here a little bit. But basically what we do is every surgeon will have their own philosophy behind a knee replacement. Whether it's how they resurface it, whether they align the knee in a certain way, or whether or not they use certain specific instruments that help them get through the knee replacement. My philosophy is pretty much I replace the millimeters of bone that I take away with the same amount of metal and plastic that goes in the knee. So we start with kind of essentially just shaving the frontal part of this knee, and that sets our alignment. And then every cut that I make, I measure with a caliper. And then I usually just put the same amount of metal back on with the knee. But there's about 7 cuts to a perfect total knee. In the front, one in the front over here, one in the back over there, and then we call it 2 chamfer cuts. So that's about 5 cuts there. And one is the tibia cut, which is just a flat cut right around the shin bone. And the last one is around the kneecap, underneath the kneecap. So that's the kind of 7 cuts to a total knee that we do.
Let's talk a little bit about hip replacement surgery. And can you go ahead and talk about, describe that a little bit?
Yeah. So hip replacement surgery, I guess before we go into this whole implant thing, we could talk about different ways or a different presentation of maybe hip arthritis. And then we could kind of go to the approaches to hip and then how to kind of deal with the hip as it comes from implant perspective and whatnot. But number one, usually hip pain will prevent with a kind of pent pocket pain. They'll have growing pain. For this region specifically, in the South, there's kind of a higher incidence of avascular necrosis, in which the blood flow to the hip for what one reason or the other decreases, and sometimes people come in with collapsed hips. That's not hip arthritis. Hip arthritis, again, is that wear and tear of the bone as well as the cartilage to the point where the ball is touching the socket. And those patients present with kind of the groin pain or the pant pocket pain. That's very important to differentiate than buttock pain. So if they come in with butt pain, then you're looking at a situation where the patient may have some lower back issues, although it can still present as hip arthritis. So we don't rule it out, but it's one of those things to be importantly aware of. So they come in, they have the kind of 5 parameters: pain, more bad days than good days, x-ray, symptoms, physical exam, as well as a election for surgery. Then we're in a situation where we're looking at what approach are we going to take. So there's something called the anterior approach, lateral approach, and posterior approach. And I'll talk about those in a second because I'm going a little long on this. That's fine. But essentially, that's up to the surgeon's preference and the patient's request. And then finally, we're at this point where essentially what we do with a hip replacement is we take away the bone that's deteriorated, which is the femur. So this is the thigh bone. And we cut away the neck. And then essentially we have an open socket that goes into the canal of the thigh bone. And we place this stem prosthesis with a brand new head. On the cup side or the acetabulum, what we do is we resurface it and put a metal socket in there with a plastic liner. And then this becomes your new bearing surface in which you're able to walk around on this construct. But that's kind of it for a hip replacement.
So by far, for example, in the knee, I would imagine degenerative osteoarthritis is probably the most common thing that leads to knee replacement. Could you say the same thing in the hip, or is it a vascular necrosis part of a good chunk of that?
I'd say osteoarthritis for both for sure, but definitely around this area, it's very common to see pretty much collapsed femoral heads come into my clinic. It's a very common thing. So not necessarily saying that it's number one here, but a little bit more frequently than what I saw in residency as well as fellowship. So,
in terms of when a patient feels it's time to get their hip replaced, is the symptoms about the same? Pain?
Yeah. So pain, and again, it's that kind of deep growing pain. They usually present with a limp, so they're going to be walking around a little bit less normal than what we were. They're going to have pain at the end of the day because it's a pound, like kind of ground and pound type of pain where they're on their feet more, so they're using it more, and they get more plain torso.
And in regards to the hip, are there treatments that can delay replacement as there are in the knee?
Yeah, we have pretty much the same modalities, which are these anti-inflammatories. We could do therapy, try for weight loss, low inflammatory eye, and then finally we could consider injections in the hip as well. So that's
sometimes down the road, following especially a knee prosthesis, patients will still complain of pain. So generally, what's the cause of that pain if they have had a total knee?
Yeah, so there is a bunch of causes, but that's very important for you to have a very good physical exam on the patient. Number one, I'd say the all cause, probably most common cause, is after the surgery they had the rehabilitation, they got very strong, but over time they just didn't keep up with either exercising or therapy, or continue to progress to try to strengthen muscles above and below the knee somehow, some way. So what they get is sometimes they get some soft tissue irritation or pain around the knee, a certain spot, whether it be a certain tendon that attaches around the knee, that could get inflamed because it's just a little weak. That's kind of an easy fix. The other problems that are relatively common are loosening or infection. Okay, so infection can occur at any time throughout the course after surgery, but it's very, very important for your surgeon not to ignore it. It's your bill panel and tests. And then the way to kind of my litmus test or to asking patients, like, do you have constant pain? Do you have pain all the time? Or did something change where you're getting better and better and now you just have pain all the time? If you do have pain all the time, again, we get to the infection early, we can take care of it relatively swiftly.
So before we wrap up, is there one thing that you might advise your patients in terms of what they can do first in their lifetime to kind of delay the advancement of arthritis and the coming of a replacement surgery?
For sure. I always just tell my patients to essentially just walk. So like, that's like, if I could give you one piece of advice for everyone, walk at least 40 minutes a day, regardless of whether you're hurting or not, because that'll just help with any sort of weight gain that you might have, number one. And then two, it'll keep your joints moving and in motion. Because what we're trying to avoid is kind of the body kind of giving us the signal to stiffen up, slow down. And a sedentary lifestyle will always just kind of enhance the process of arthritis or anything else that we have going on in the body. So for me, it's just about motion and making sure that they continue walking.
Thanks very much for joining us today and sharing your expertise on arthritis and joint replacement. Really appreciate it.
Thank you so much. Thanks for having me.
Whether you are dealing with joint pain yourself or caring for a loved one, we hope you find this information that we presented today useful. For our listeners who want to make an appointment directly with one of our orthopedic experts, you can call 956-362-MOVE or 956-362-6683. To our listeners, thank you for joining us today, and don't forget to follow and subscribe to our podcast, DHR Health Talks. And don't forget to share this with somebody who might benefit. Stay well, stay informed, and remember, we are DHR Health. For you, for life.